this is Jeff Tyler, Interventional Cardiologist at Orange County Heart Institute in Orange, California. I wanted to share with you my top 3 tips for pulse management, as well as how to know that you've done a great job modifying the lesion and it's ready to be stented. So tip number 1 here is eccentric and nodular calcium benefits from the extra pulses that we're able to give with the C2 Plus catheter. Generally for my procedures, I image up front with intravascular ultrasound or OCT. During that time, I'm getting 2 pieces of information. Number 1 is what's the true size of the vessel, because I want to choose a Shockwave that's 1-to-1 size, as well as what is the morphology of the calcium, and are there certain segments that are eccentric or nodular. When you have eccentric and nodular calcium, you want to focus the majority of your pulses on those segments so that you adequately treat them. And generally, I give all 120 pulses, even if I feel that the lesion has been adequately treated with a balloon that looks fully expanded. Tip number 2 here is for those patients that have a challenge with hemodynamic stress during periods of balloon inflation, whether or not they're supported with an Impella, I often will limit my pulses to fewer than 10 in a row. And I find that allowing the artery to breathe during those periods where I just give 2 or 5 pulses prevents any challenges both during the procedure or long-term with hemodynamic stress or accrued ischemia. Number 3 here is how do you know that you've done a great job modifying the lesion with your balloon? Well, first clue is you'll often see the Shockwave balloon that begins with a waist often be fully expanded. But I like to know that my lesion's fully treated so that my stent becomes optimized and I don't have any stent regret. So what I do at this point is I then will take a 1-to-1 size non-compliant balloon and go up to nominal pressure. And if it looks well expanded, and sometimes I'll do it in 2 different views to get orthogonal planes, then I know I'm going to have a great result with my stent. Intravascular imaging, such as OCT or IVUS, can sometimes show the fractures and will, but it also sometimes doesn't have the resolution to identify it. So for those cases, and pretty much all of them, I focus my attention and my decision when the lesion's been fully prepped to when I see the NC balloon fully expanded.